We're going to talk today about Chapter 5, Thinking Critically, Analyzing Data, and Making Nursing Judgments. We can come to college and we can learn all about assessment procedures, different types of equipment, but what we also learn is how to critically think. And this is so important because as a nurse, you're going to take a lot of information about the patient and lab work and maybe subjective and objective data, and you're going to bring this information together to infer some type of diagnosis and then maybe make some clinical judgments related to that. So there's no more memorizing information. Now we're going to start applying it to the patient. So we're going to practice that critical thinking aspect. So we have to analyze the data. We have to take all the data that you get from your patient and looking at the big picture and bringing everything together to make a decision. So we do the data analysis, which is the second phase of that nursing process. The diagnostic and clinical reasoning phase, where we bring all the data that's collected. So maybe it's something the patient said, maybe it's part of their history, maybe it's part of diagnostic data. So we'll take all those things together. So we do this to try to infer a nursing diagnosis, and we'll talk more about nursing diagnosis as we move forward. But the diagnostic reasoning helps us interpret the data. We need to understand what we're looking at. Why is this relevant to this particular patient? So when a nurse is critically thinking at the bedside, we process the information, maybe things that you've known, past knowledge, your gut feeling. I can just feel something is not quite right. And your cognitive abilities. And we formulate a nursing diagnosis, a NANDA diagnosis, and so we can start working toward understanding any nursing interventions that might help to move our patients into recovery. So, how do we test this critical thinking mindset? Do you make a snap judgment, or do you get all the facts first? Do you does your opinion, is it supported by data, rationale, and peer-reviewed literature? Evidence-based practice and theory, all are based out of literature. Do you explore and consider any alternatives before making a decision? We have, for people are different, patients are different, and sometimes things are expected and sometimes things are not. So just because somebody is running a temperature of 99, that doesn't mean that that patient is not febrile. And that may seem foreign to you, but say the patient's baseline is a 96. We have to consider that that 3 degrees might make somebody uncomfortable. So looking at the big picture, we need to know the difference between facts, opinions, cues, or inferences. Just because your patient's family says something, that does not make it a fact. We have to look at things as subjective and objective to try to find the truth and the best possible judgment based on the information that we have. Do you ask the patient, or do you ask someone to clarify any information if you don't understand? Um, if your patient, who has um, blood sugar of 350 and they are feeling completely fine, they say, that might seem odd to you. How does this person have such a high blood sugar and they're not symptomatic at all? That doesn't make sense. So maybe we want to clarify. Have you ever had a history of diabetes or anything like that? Always asking questions to clarify is very important to validate the information. And say my patient's like, yes, I had no idea my blood sugar was so high. Then you might go to your charge nurse or someone else, your clinical instructor, and say, hey, I have this very interesting case. My patient's blood sugar is very elevated and they're completely asymptomatic. What do you think about that? And so we can start having these type of conversations as professionals with each other. So maybe you use some past knowledge and experiences to help you understand some of the data. When I looked at this x-ray last time, this is what was happening and this is what it looked like. And you can bring some of that past experience as a piece of the puzzle, but you have to take all the pieces to make the puzzle. Do you try to avoid bias or preconceived ways of thinking? There is never or always. Those things don't typically happen in nursing. There's always listen to me. There are typically some things that you would expect and then things that are unexpected. So you have to be thinking about that. Just because this other patient had a similar diagnosis does not mean those patients are going to look the same. We have to take the big picture. A critical thinking mindset requires a lot of reflection and asking questions. Here's a cheat sheet of critical thinking questions you might be able to ask yourself. For example, who benefits, who is this might be harmful to, who makes decisions, who's the most directly affected. Most of the time in nursing, you're talking about your patient. But if you're asking questions about a situation, you might also ask some other pertinent questions as well. What are the strengths and weaknesses in your thought process and decision? Is there another perspective? Can you access other resources to get another perspective? What would be the best and worst case scenario in a situation? We do this a lot as we're analyzing disease process. We look and see where is our patient in their recovery? Are they recovering or are they in decline? So you have to look at what's happening with your patient so you can understand and make clinical judgments. Where might include where could this be an issue? Where do we go for help if we need help with the situation? Where are areas for improvement? That's always important to look at. You can always learn from every interaction with your patient. When you could identify when this situation would cause a further problem, when do you know that what you're doing is making it better? A lot of times we look at lab data and we can see our patient who has pneumonia, their white blood cell count is trending down over the last 2 days. So we can see that because of what we know about physiology, that those are some cause and effect situations there, right? As the infection gets better, the white count trends down, antibiotics are working. But we look at this data in a big picture, critical thinking type format. When you think about why, you can see why is what is happening a problem? Why is the fact that somebody has a low oxygen saturation in their arterial blood gases, why is that a problem? Well, we know hypoxia is a dangerous thing for our patient. It causes a lot of assessment findings. And so these things are important. We need to think critically, ask these questions. Who needs to know about this? Why do they need to know about this? What makes something important to report to the provider? If you ask yourself, why would I want to notify the physician about this particular thing? And hopefully, especially as you're moving through this process, you realize that maybe we might need some further orders. Maybe the interventions that the doctor has ordered is not meeting the needs of the patient, and we need to report changes so we can try to get other interventions to help this patient. And how? You might think about a situation with your patient. How could this be similar to something else that I've experienced? It's never going to be the same because your patient is different, but how are things similar? How do we approach this with safety for the patient? This is really important because you may want to fix a problem, and if you don't do it safely, it could cause another problem. For example, we might want to address this patient with medication, but that medication can have side effects. So we want to make sure that we are safely administering these type of things. Another example might be you may be familiar with some of the vancomycins or antibiotics. So when we give these medications in the IV, we have to make sure we have a really good IV site, or we provide a peripheral inserted central line, because these medications can be caustic to the veins. And so, yes, we're fixing one problem, but we possibly could be causing another. So we need to understand the big picture and take those things into consideration. Is there benefits for the interventions that we're doing? These are important questions to ask. So I think that when you are doing something, start guiding some of your thinking. It's no longer just a task that you're completing. As a registered nurse, we need to understand why. What is the purpose? What is the reasoning? Because if you understand why and the purpose, you're able to make a better clinical judgment. So, the 7 essential critical thinking characteristics. Number 1, keep an open mind. Always have rationale to support your opinions. They're, your opinions are not based in fact unless you have something to back that up, resources, etc. Um, other than Wikipedia, or Facebook, you need to have some type of rationale and basis to back that up. Reflect on your thoughts. Think about, okay, so have I utilized all the tools in my tool belt to help me reach this conclusion? And maybe the conclusion is not correct and we need to rework it. But think things through. Take your time. You can use some of your past clinical experiences to build knowledge. In the past, when I've had this type of conversation, it works better if I make eye contact, if I remain in a calm tone, if I am not fidgeting myself. You can use those past experiences in your conversations to help bring that professionalism into this conversation. Always be aware of the interactions of others and be aware of the environment. Know the room you're working with, the tone, and the how you're interacting with the patient. Is being emotionally intelligent is what we call it. You have emotional awareness, emotional integration of your thoughts and feelings into your conversation. But it takes being aware of the room. If you walk into a room and your patient is in the dark and they're curled up in a ball and they're crying, you're not going to go in there and say, hey, So awareness is very important. So when you are collecting data in this diagnostic phase we talked about, you are going to group and organize your data. So maybe you have your demographics. Maybe you have your information like we learned in chapter 2 with subjective data. Maybe you have your physical assessment in that space. So subjective would be your health history, objective would be your assessment. Then maybe you have lab and assessment information. Maybe you have your cold spa conversation, and you're bringing that information together to understand what is happening with your patient. So when you're trying to make a decision about what you think is happening, what is this patient's diagnosis or nursing diagnosis, you validate with and can look at some of the expected values and see what your patient has and compare those. When we cluster all this data and you make an inference about what's happening with your patient, noting the client's problems and what is happening, what's going on, what's the nursing diagnosis, we can formulate some clinical judgments. My patient has a complaint of pain. So my clinical judgment is that my patient is in acute pain. That is a NANDA diagnosis. So the evidence is the patient has pain during the cold spa with a severity of 6 out of 0 to 10 and is moaning and holding his abdomen. So you have your NANDA problem and then you have your evidence and you take those things to make your clinical judgment. And then you can verify and validate that with the patient as you're talking to them about your cold spa. So this just walks you through that piece that we just talked about. You're going to collect your information, subjective and objective data. Then you're going to cluster. Look at the abnormal findings, things that stand out to you. You're going to draw inferences, maybe consider some nursing diagnosis. Then you're going to propose possible nursing diagnosis. And an actual diagnosis is a problem that the client is currently experiencing. And you'll see in our case scenarios this semester, each patient that we are going to talk about actually has a NANDA problem. So the actual problem is going to be a priority over something that might be a risk, because the actual problem is going to have the most direct impact on the patient. A risk diagnosis is something that there's a potential, but it's not there yet. So next we're going to look at some defining characteristics. The evidence. On this slide, we talk about using impaired gas exchange. So if there's impaired gas exchange, to me that means that the gas exchange in the lungs is not as high as it needs as expected to be. So that means there would be a low O2 sat. That would be your evidence. Then we're going to confirm or rule out the diagnosis. We're going to validate, maybe look at some other information if we need to validate for any other problems. But we're going to really focus on actual diagnosis this semester as we start talking about NANDA diagnosis. And then the last, you're going to document the conclusion. So we're going to show you how this is the actual diagnosis, and this is the evidence that goes with that diagnosis. There is a possibility you could have a secondary diagnosis as a risk, but you will always have an actual diagnosis first as the priority. So in the past, there have been some 3-part diagnosis, but this semester we're going to focus on the the NANDA diagnosis, which must be a NANDA diagnosis, and then the evidence. So you'll see in here it has a part 2, but we're not going to focus on that as much, and you'll see that on your assessment forms as we get there. So let's focus on the diagnosis of ineffective breathing pattern. And then the part 3, or the evidence, is the respiratory rate is 28. Nasal flaring, tripod position. The patient is breathing in a labored pattern. So that is your evidence for that diagnosis. So here's a patient scenario. So you can look at some of the data and how it's written up, and then refer back to the NANDA diagnosis and the evidence we just talked about. Ineffective breathing pattern related to impaired chest wall expansion. Again, I'm not going to have you focus on the related to, but your AEB is your as evidenced by. Respiratory rate of 28, nasal flaring, sitting in a tripod position. Again, that is distress for that patient. So risk diagnosis is the patient is at risk for if the nurse doesn't intervene. For example, we see this with skin integrity. That's a big one that you're going to see all semester long is risk for skin integrity. We talk a lot about skin integrity because wounds and a lot of things like that related to pressure ulcers are preventable. We can relieve the pressure and cause less wounds. It's our role to do that. So we will talk more about risk diagnosis, but just know that a risk diagnosis might occur if the nurse doesn't intervene. Health promotion diagnosis, again, this is is it valuable? Yes. But is it the priority? Does it have the most immediate direct impact on that patient? No, it does not. So, and it can be difficult to get evidence for and symptoms, right? So, but you'll talk about these and possibly in health promotion. So, collaborative problems and referrals. So if your patient has an issue, nurses are able to refer either to wound care or to nutrition. And if there is an issue that we identify through our talking about problems, we are able to do that referral. An order is not needed. So we prioritize problems. This is part of your critical thinking. You need to know what has the most direct impact on my patient. Obviously, number one is the emergent, life-threatening, my patient is in danger. So that means they have airway, breathing, cardiac problems, maybe, heart attack, things like that would be considered cardiac problems. Vital signs or blood pressure super duper high. Those are things that we need to deal with right away. The other things, the next level that needs prompt intervention are any mental status changes, any sudden changes that is emergent. We need to rule out stroke for these patients. Any acute abdomen pain, acute pain, those are always priorities in your critical thinking. We would also say safety and things like that. Keeping your patient safe is a big priority. Risk for falls, things like that is very important. I would like to add it's something back with the cardiac and circulatory problems. So for circulation, if your patient does not have pulses, that is critical. No blood flow, that tissue dies. So be sure that you know that cardiac circulation, that is pulses. there's no perfusion to extremities. The other thing I would say is acute abdomen. When somebody has a sharp, severe pain in their abdomen, that is an emergent situation. We need to evaluate that patient immediately. So, but everything is um, sudden changes, breathing, all those kind of things. That is always a priority over something like um, impaired mobility. Is impaired mobility bad? Yes, it's not a good thing. We don't want your patient to have impaired mobility, but none of that matters if they're not breathing, right? So that is always the priority. Students ask all the time, how do I know? I don't work in the hospital. How do I know what's a priority? Well, it is going to, whatever's going to do the most damage to your patient faster, we need to fix that first, right? Thank you, and this is the end of the presentation.